Good afternoon, everyone. Welcome to this UKFPO webinar about sustainable quality improvement. My name is Kata Varnai, and I am the Senior Project Manager for Education and Support at the UKFPO. I'm pleased this afternoon to have with me Ioma Ratnapulli, who's an Education Fellow at the Centre for Sustainable Healthcare. Sustainability is an important issue for all of us, and the UKFPO want to particularly support the sharing of good practice in sustainability in healthcare. We are looking to introduce more elements on this into the UK Foundation Programme curriculum and to signpost our foundation doctors and trainers to useful information around the UK. Ioma is one of many colleagues who are working on spreading education on sustainable healthcare, and I'm looking forward to sharing her knowledge with our foundation programme community. Please use the Q&A box to submit any questions during Ioma's talk, and we will go through them at the end of the webinar. The webinar is being recorded, and we will share the recording on our website shortly after this session. Supporting the webinar today in the background are Sophia and Tamika from the UKFPO team and Tony Choules, Clinical Advisor to the UKFPO on education and support matters. Tony will be looking at your questions in the Q&A, and we will pick them up after Ioma's talk. So I will now hand over to you, Ioma.
Thank you, and thank you for this opportunity to talk. So I'm Ioma, I'm an Education Fellow at the Centre for Sustainable Healthcare. I'm just going to get my slides up. So my background is that I'm a HIV and sexual health registrar in South London, and I've taken a year out as an out-of-programme experience to be an Education Fellow at the Centre for Sustainable Healthcare. And I'm going to talk to you guys about sustainability in quality improvement and hopefully show you all why this is an important topic and also give you the tools to start doing some sustainability within your own quality improvement projects. So the aim of my presentation today is to firstly introduce the relationship between climate crisis and healthcare and hopefully show to you guys as our health professionals and the future of our health provision why this is something that firstly you should know about and also why it should be something that we prioritise. I'm also going to explain the principles of sustainable clinical practice and provide an overview of sustainability in quality improvement, or as we like to call it, SUSQI, and show you the framework that we encourage people to use to make quality improvement changes. And then I'm going to go through a few case studies showing SUSQI in practice within the NHS. So I wanted to start off by talking a little bit about what climate change is. It can feel like quite an overwhelming subject and it seems so broad and sometimes we don't really understand the sort of basics of it. So I thought it would be good to start with this so that we can really all have the same foundation of knowledge. So if you think of the Earth that we live on, there is a blanket that sits around that Earth and it's made up of greenhouse gases. And the greenhouse gas that we think about the most is carbon dioxide. It makes up about 86% of greenhouse gases, but there are others like nitrous oxide and like methane as well. And that blanket regulates our temperature within our atmosphere. But we know now with human activity that we are emitting more and more greenhouse gases. So that's through, using fossil fuels, through our travel, through agriculture as well. And that means that blanket has got thicker and thicker and thicker. And as a result, it's changed the balance within our atmospheric temperatures. And the consequence of that is multiple. So we've seen lots of floods, unfortunately, within the UK recently. So we're seeing changing rain and snow patterns. We're seeing more droughts and wildfires. And we often see in the news about the rise in sea levels, and it also is changing the ecosystems within which we live. And this is it's no longer a slow process, it's something that is accelerating. And this was a picture that I took from BBC Weather in 2022 when we had a drought in the UK. And it shows the number of years above 35 degrees. And what you can see is between 1900 and 2002, this had only happened 9 distinct times. But since 2003, it's happened 7 times. And the IPCC, which is the Intergovernmental Panel for Climate Change, they report that there's a 49% chance of us reaching that temperature rise of 1.5 degrees in the next 5 years. So we have to really act on this now. And the reason why we should be caring about this as a health professional is that it is affecting our patients. So this picture is a young girl called Ella Kesey Deborah, who was 9 years old when she passed away, and she was one of the first people to have air pollution down as a cause of death. And in the UK alone, we estimate that there's about 40,000 deaths a year related to air pollution. So I'm going to talk through the sort of vicious cycle of climate change in healthcare. So we know that climate change worsens health outcomes. And the way that it can do this is both directly, so through things such as air pollution, through extreme weather events. So we saw when there was the drought in 2002, there was about 3,000 excess deaths related to that extreme weather event, but also indirectly. So things like crop failure, we will start to see more climate-related migration as areas are less hospitable. And we're also seeing change in distribution of vector-borne diseases. So you may have seen over the summer, there was some cases of things like malaria within Europe. So these are all things that are going to increase demand for healthcare. Another thing that we should all be aware of is that climate change exacerbates pre-existing health inequalities. So firstly, it's those who are contributing the least to the climate crisis that will feel the effects the worst. But also it's already the people who are in low socioeconomic areas who are going to be more vulnerable to worse health outcomes. And there's evidence that the richest 10% globally are responsible for almost half of total lifestyle consumption emissions. So you may often see people saying that climate justice is social justice. And it's not necessarily just health risks that are the problem. Climate change also changes the infrastructure within we work. So you can see here, these are some actually quite recent news clippings showing how IT systems failed in the heat wave, how there's been floods in hospitals, and then I already mentioned about the excess deaths in the heat wave of 2022. This diagram shows that if we were to try and combat climate action and reduce carbon emissions, that there are multiple pathways which lead to health benefits. So things like improving public transport, increasing access to green space, increasing locally grown food or reducing meat and dairy intake, all have multiple health benefits which are quite expansive and ultimately will result in reducing social and health inequity. So this is something on a population level and on a global level that we really need to think about, and the time is now. But on the other hand, if you look at the other side of this circle, so we know climate change worsens health outcomes, it's going to put increased demand on what is already a stretched healthcare system within the NHS. But actually, our healthcare service provision exacerbates climate change. So we know that the NHS is the biggest public sector carbon emitter in the UK. 1 in 20 road journeys are related to healthcare, and 2% of global plastic is medical plastic. We have already plotted how we are contributing to climate change. So this image is from the Delivering Net Zero report, which was released in 2020. And the Greener NHS team calculated and estimated how healthcare is contributing to climate change and where the biggest hitters are for that. So they did this in 2 scopes, well, 2 different divisions made up of 3 scopes. So the first in the white is the NHS carbon footprint, and this relates to the emissions that the NHS has direct control over. Whereas the carbon footprint plus are emissions that we can influence. So we can influence, for example, how patients and visitors and staff travel to work, but we can't necessarily control that. And it's important to know that emissions vary in terms of how much they contribute in total. So very often when we talk about sustainability and environmental issues, people think about water and waste and recycling. But what you can see, hopefully, from this pie chart is actually that makes up quite a small percentage of the NHS emissions. It's about 5%. The major contributors are things like pharmaceuticals, medicines, chemicals, and then also our supply chain. Some surgical equipment, for example, will come from very, very far away from overseas and may just be single use. So the idea of sustainable healthcare is to work smarter. so that when we are providing healthcare, that we're doing what we can to reduce the environmental, social and financial impacts of how we work. And this is where the concept of sustainability and quality improvement comes in. So it's about taking the knowledge that we know about sustainable healthcare and why we need that, and trying to put it into action. And in the next few slides, I'm hopefully going to help work through that with you guys. So this is an image that's from the Royal College of Physicians, and it shows how they've incorporated sustainability within the definitions of quality. And it states that this must run through and moderate the other domains. It's also in the GMC outcomes for graduates that we should be aware of sustainability and the need for this. But healthcare should be considered not only in terms of the service that we provide for our patients today, but it's about safeguarding the populations for the future and not using all of our resources at this point. So although we want to always provide high quality healthcare, we argue that we also need to improve value. So a service can be high quality, but it can be low value. And given that resources are finite, we ultimately want something to be more valuable. And we have this idea, which is from Francis Mortimer, who's our medical director at CSH, of sustainable value as sort of evaluating change and measuring impact. And it's a family of measures. So on the top, we've got the ultimate aim, which is that we would always want to improve outcomes for patients and the population. We would never advocate for something that would put our patients at risk. But we also need to balance it alongside environmental, social and financial impact. So what we're aiming for is improving clinical benefits, improving wider public health benefits, but at the same time trying to reduce any environmental and financial impact and add in social value at all points when possible. So that's not just to patients, but also to staff and the people who work within the healthcare system. So the idea of improving sustainable value is a very nice idea, but how do we actually get to that point? Well, this driver diagram hopefully shows that. So driver diagrams are sometimes used within quality improvement projects to sort of streamline how you will get to your aim. So our ultimate aim is here on the left, which is improving health and reducing carbon. And the way that we can do that is by either reducing healthcare activity or by reducing carbon intensity. So if we focus on the first part of reducing healthcare activity, our first aim would be to prevent ill health for people. So if we can prevent people having to access healthcare, that would be wonderful. It's not always possible. So if that's the case, if people are unwell, we want to empower patients to self-care and to manage themselves in the community when possible and prevent ill health. So exercising, moderating their alcohol, reducing smoking, those are all ways of empowering our patients. But when people do need to access healthcare, we should be providing what we call lean pathways. And what we mean by lean pathways is that we're reducing any wasteful steps. We're not duplicating work, that all steps within a process have a value. And sometimes you can feel that when you're working in a hospital, that maybe two people are sort of working on the same thing through different specialties, and actually you want the same outcome at the end. So it's trying to work a bit smarter. And then in terms of reducing carbon intensity, we always want to be looking for low carbon alternatives. So for example, telehealth, which came up so much within COVID and the pandemic, it actually, when it's clinically appropriate, can be a really great low carbon alternative. And when we talk about operational resource use, that tends to apply to things like estates and facilities. So making sure that there are LED lights, trying to use taps that are less wasteful of water. So in surgery, you can use foot control taps rather than the normal taps, and that's shown to save some water. So these are all what we call the principles of sustainable healthcare. And these are the principles that we need to bear in mind when we're thinking about interventions and improvements within QI projects. And the top four are sometimes known as the principles of sustainable clinical practice. And then the third is more, as I said, in relation to estates and facilities. So I'm going to move on now to work through the SUSQI framework, and then we're going to go through each of those steps using an example. And then at the end, I'm going to show you a couple of different examples within the NHS that we've helped support. So the green is the SUSQI framework. And this is really an overview of the 4 steps, and we've put the model for improvement, which is one of the QI tools that is sometimes used, in blue. And as you can see, the steps map up quite well. And the idea of this SUS-QI framework is not that it replaces standard QI approaches, but it's a tool for integrating sustainability into a QI process. So we're not trying to make things harder for people or add an additional step. What we're trying to do is just adjust what already exists to include sustainability. And the aim, as we've said already, is to improve sustainable value. And to do that, you need to firstly understand the current system, which is step 2 of studying the system. You've got to use the principles of sustainable clinical practice. So that's their prevention, patient empowerment, and so on, to design your improvement. And then ultimately, with any QI project, you want to see what's the impact of what you've made. Has it been helpful? Does it need to be changed in another way? So let's work through these steps. So the first step is setting a goal. And the aim from a SUS-QI perspective is that you want to develop a sustainability lens. So you want to focus on what's the environmental saving that you can make, or what is the issue that's making you worry about the climate impact of something. So the scenario we're going to work through is something that you probably all come across. This is an imaginary patient, Elizabeth, who's 83 years old, who's admitted via ambulance with worsening breathlessness. She's treated for an exacerbation of COPD and is admitted to care of elderly ward. She has a short stay requiring minimal therapy and continues her regular medications. She goes home via taxi. Her follow-up is a COPD nurse appointment in her GP practice, and she's prescribed a new metered dose inhaler to manage her exacerbations. From a social perspective, she lives alone. She lives near a busy road. She has a 1 carer a day visit. And she's been into hospital at least 6 times already this year. And you talk to your team about this, and everyone says, well, actually, it's something that we're seeing quite a lot of. So you wonder, how could you reduce the environmental impact of these recurrent readmissions? And very often, I think we think about these things, but we don't often think that we have it within ourselves to make this change. And I'm hoping that we can work through this together to show that you guys have exactly the tools that you'll need to make a really big impact on patients like Elizabeth. So you've set your goal. You want to reduce the environmental impact of recurrent readmissions for patients like Elizabeth. So number 2, you want to understand the environmental and social resource use and impact. So you want to study the system, as we call it. Now, to do that, very often we need to work with other people, because we sometimes will just see a certain aspect of a pathway or a process and not see the whole thing. So in any QI project, I think it's always important that you try and build an MDT team so that you're capturing the whole picture. And we really advocate for using something called a process map to study a system. I'm going to show you an example of that now. So this is basically a depiction of the blurb that we read. So you've got your patient, your starting point here, comes into A&E, is reviewed, and then the diamond represents a decision point. So there are 2 different options of whether she's admitted or not admitted. And then you can basically plot every step along the pathway of the process that you want to look into. So this can be adapted in any way for many different situations, and it's a good way of really trying to map the full extent of a process or a pathway, and then to allocate where the environmental or social or financial resources are. So let's do that in this next step. So we're going to focus on the environmental resources to begin with. And this is an example of how you do that. So this flowchart is exactly the same as the first one that I showed you. But what we've done is we've classified the different environmental resources, and then we've plotted them in the little green numbered circles next to each step that it's applicable to. So for example, if we're thinking about medication use, it would be used when Elizabeth comes into ED, when she's having an inpatient stay, when she's seeing the nurse, when she's having her reviews, when she's discharged home. And so in this way, we can try and really create an exhaustive list of where all the resource use is. And it's important to remember from the pie chart that I showed you from the Delivering Net Zero report that not all of these resources are equal in terms of their emission proportion within the NHS. So for example, number 8 is the water use. That's probably minimal compared to, for example, medical supplies number 2. And this graph depicts that as well. So you can see that this is from 2018, but it's relatively still the same proportions, that medical equipment and medicines have a really high carbon emission. compared to, for example, waste. And another thing is inhalers in this scenario specifically has quite significant emissions related to it. And so when we look at this in more detail, we can identify what we call carbon hotspots. So carbon hotspots are areas that are responsible for sort of an unusual intensely sort of concentrate of greenhouse gas. It is useful because it can then identify where you might want to put an intervention in place, or where you might want to think or investigate slightly more as to why this could be a hotspot. So this is one way allocated the environmental resources and I make an intervention. So for this scenario, we can see that the inhalers are very prevalent, and we know that inhalers are a big source of emissions. But even if we target the hotspot in our improvement from an environmental perspective, we still want to look at it from a social perspective, because remember, that's also part of sustainable value. So let's have a look at that. So social sustainability is about avoiding social harm and building social value. And I think this quote from Sir Michael Marmot, who's an expert in health inequalities, actually really sort of ties it all together quite nicely. So health inequalities and social determinants of health are not the footnote to the determinants of health, they are the main issue. And what we're trying to emphasize here is that we can look after people within hospital and we can make people better, but when their social situation is affecting their health, and that's what we mean by social determinants of health, so their employment status, their immigration status, their community. So there's a limited amount that we can do within hospital within the long term to make significant change if we're not trying to also improve people's social situations. So if we think about that from Elizabeth's situation, one way of looking into the social impacts could be something like this, which is called a social impacts table. Now, this table allows us to look at the social impact of the current system. So we still have not made any intervention change yet, but we're just trying to understand the social situation of these frequent readmissions. So for example, it would be causing patient agitation and frustration of their time, their travel. No one likes to be in hospital. It can be frustrating for staff as well. It can be an over use of resources. And so those are some of the social impacts we can think about. If we want to think about how we would measure that before and after an intervention, it tends to be qualitative. So we would maybe do patient or staff surveys. You could do rating scales. You could look at procurement data. But it's always something that's really important to think of. I think social value is quite difficult, and so we tend to avoid trying to measure it, but it's so significant in its impact that if you take the time to think about it early on, then you can measure it quite straightforward before and after an intervention. This is a social determinants of health table, and this is an alternative way of implementing social sustainability, and it's really trying to target a social determinant of health as a means for your intervention. So either to prevent ill health, so we know prevention is one of the principles of sustainable clinical practice, but also to reduce subsequent healthcare activity. So for example, in Elizabeth's case, if her housing is really poor, if she has mold growing on her walls, or she's got poor ventilation, that could be why she's having recurrent readmissions. Equally, if she has poor health literacy and she doesn't really understand self-managing her exacerbations, that could be why she ends up coming back into hospital many times. So these are examples of how we can think about the social systems that patients live within. So let's now move on to designing the improvement. So at this point, we want to try and remember the principles of sustainable clinical practice and how we can think about innovations that would relate to those. So this is sort of a brainstorm of that for Elizabeth's situation. So from a prevention perspective, maybe we could address social isolation. From a self-care perspective, maybe better education on managing her exacerbations at home. Lean pathways, an example could be adding a geriatrician review to ED rather than wards, so that she's getting that review earlier on in the pathway. And a low carbon alternative could be switching to a dry powder inhaler over an MDI, which we know has got less emissions. And those all sound really good, but they're not necessarily all feasible. And so it's important to try and prioritise your improvement idea. So look at the health impacts, the environmental impacts, and the social impacts and the feasibility. So this table scales all of those for each of the different interventions. And what you can see from this is that probably the switch to a dry powder inhaler is a more feasible example. It may not have the biggest social impact, but it would still have quite a significant environmental impact. So this is something that's great, again, when you've got an MDT team that you can brainstorm together and think about what's feasible, what can you actually do, and then what would the impacts be as well. So we're going to move on to the final step of the SUSQI process, which is measuring impact. And I think sometimes this feels like the scariest part of the framework because it's a bit of sort of calculating things and almost like the crunch point of has your intervention made an improvement. But I'm hoping I will show you that it's not so scary, and actually even thinking about things from a carbon perspective is not that intense and anyone can do it. So once you've designed your improvement, you've implemented it, now you want to measure those impacts across that, we call it a triple bottom line, so the environmental, the social, and the financial impacts, but then always never forget your clinical outcomes as well. So when we're thinking from an environmental impacts perspective, there are two ways of doing things. The first and the quickest and easiest is a non-carbon method, and that's really showing a reduction in resource use. So, for example, the number of face masks that you're using before, if you're using disposable masks and then you implement a change where people use reusable PPE, you're going to show that there's a reduction of sort of procurement for those face masks. That would be a really straightforward, non-carbon method of measuring environmental impact. More and more, however, people are doing a carbon footprinting, and that's basically an estimation of carbon which is allocated to an activity. So, as I said early on in this talk, there are lots of greenhouse gases, but when it comes to carbon footprinting, we talk about carbon equivalent gas, and that basically means all the greenhouse gases equivalent to a carbon measurement, because that's the thing that we most talk about and we would quantify it. So there are already some calculators out there, so you don't even have to do all of the maths. So for example, there's this one, which is from the Sustainable Healthcare Coalition, and they use carbon by units of healthcare. So if you know along a pathway how many GP visits, how many ED visits, or how many bed days a patient has had, you just type those into the calculator, and there are already emission factors that have been calculated, which you'd multiply it to get your carbon equivalent gas amount. So it's not necessarily something that you have to go into the details and understand, but just know that there are lots of emission factors out there, and that's what you would multiply an activity for. So someone has worked out either what the emission factor for that is, and then how much roughly carbon it will be, because carbon footprinting is all estimation. It's not an exact science. But if we're all using roughly the same method, then it's comparable. And that's really what we want when we're doing projects, so that we can see, is this saving more than this, or is this an equivalent saving? And this is a table which shows you a similar process for the emission factors, as I said. So if you have the activity data, which is something that is in your hands, so you will know roughly how many of which medical supplies are being used, you can work out travel from travel surveys from staff or patients, energy information. You can get that from your estates managers, for example. So you can find out the amounts of the activity, and then you can multiply it by the pre-existing emission factors. And I'll show you where you can access those in the last few slides. Then you can work out your own carbon footprint. Now, I said in terms of measuring social impact, it can seem a bit overwhelming, but as I said, doing something like a survey before or after your intervention will help you to show whether you've increased or decreased social value within your intervention. So there'll always be a little bit of qualitative and a little bit of quantitative work within sustainable quality improvement projects. So I've run through the process, but now I'm going to go through some practices that have actually already taken place to give you some examples of things that you could maybe adopt where you are. And the key in SUS-QI is that we're not asking you to reinvent the wheel every single time. Lots of people have done lots and lots of good work, and we have a case studies library that you can access and look at. And what we advise is that you just take projects that have been successful and employ them where you work, because it's all about embedding and spreading sustainable quality improvement. And if we can do that on a larger scale, if people implement these projects that people have worked hard on and already shown work, if we can implement them in more places, then we're all going to be helping reduce the NHS carbon emission. So I've tried to pick ones that might be relevant to you guys as foundation doctors, but I'll signpost you to our resource library at the end as well, where you can actually filter through like specialties or clinical principles that you want to focus on. So this first one is from South Warwickshire University, and it's something that I think we could probably all relate to. So routine blood testing, and you know, at the end of the day, when you're trying to put all the bloods out for your patients tomorrow in the ward, and you're just ticking as many things as you think you might need or that your consultant may ask you the result of tomorrow. And the aim was to reduce low value and unnecessary blood testing in the care of the elderly inpatients. So they identified that there were already a lot of blood tests that were being done or being requested that weren't necessarily adding any value to the patients. It wasn't necessarily changing their management plan. It wasn't necessarily helping figure out what was happening. It was just like a routine thing that people were doing. And so they implemented a sort of campaign. They did a bit of education. The first thing that they did was a baseline audit. So most of these SUS-QI projects start with a baseline audit, so you know what's the process already. So they're studying the system. So they worked out how many requests were being sent out to phlebotomists across their care of the elderly ward, and how many tests on each of those requests were being added. And then they brainstormed what were the issues with the routine blood tests. So within the care of the elderly population, it can be really difficult to get bloods. You can end up with quite significant bruising. If patients have got cognitive impairment, it can be quite traumatic for the patients and for the staff who have to do it. And also sometimes you're waiting for results to come back, and it can delay sort of a patient flow process. So they did their baseline audit. They did some education. So they just did, you know, within your academic meeting, they did a little presentation, they put posters up, and they made a little template for you to really think about what orders you were requesting. And then they re-audited afterwards. And what they found was that they were able to successfully reduce testing across the 3 wards by almost 10%. And they worked out the environmental savings, and that's based on reduced consumables. So, for example, the butterflies that were saved, the blood bottles that were saved, but then also the blood processing time, so the lab time that was saved. And all of that was equivalent to more than 2,500 miles driven in an average car. And financially, over a year, it was estimated that that would be about 18,000. From a social perspective, staff and patients agreed that there was a problem. They gained time, the lab staff gained time, and patient satisfaction from not needing unnecessary bloods. So this was quite a straightforward SUS-QI project, which had really significant clinical, environmental, financial, and social savings. And very often, sometimes we think that doing a project and focusing on environmental savings would mean that it costs more, or that it would mean more time. But this shows that actually you can save money. Normally what's good for the economy is good for the ecology as well. And then also patients and staff always seem to tend to save more time when you're making a process more lean. Another example, this is from theatres. So this was from Wales, where they shut down their elective theatres overnight. So they had emergency theatres and elective theatres, and after 5 o'clock or during the weekends, only the emergency theatre was being used, but elective theatres still had all of their equipment turned on. So they identified that as the issue. They studied the system. So during a night shift, someone did an audit of all the equipment that was still left on in their elective theatres, and they did that over a period of a week. And then they worked within a team to work out what was safe from an equipment perspective for them to turn off and on in between. And that's really important because it's a change that will affect a lot of people. And then they implemented that change, and they found that almost 50% of the equipment switched on in the elective operating theatre was not being used. So that's a really significant potential savings. There was no negative impact on patient care. Their environmental savings was equivalent to about 120,000 miles driven in a car, £26,000 per year. And they had some unintentional social savings. So what they didn't realise was the sound that was coming from the ventilation system. Just by being able to shut that down overnight, that made a significant change to patient satisfaction. And being able to make a change within their hospital also really brought their staff together. And it's always nice to know that you can make a positive change within your working environment. This is a PPE example, which is something that we all know that since COVID, PPE use is not necessarily always appropriate, and it's increased quite a lot. So in North Hampshire, this was the infection prevention control team who did this trust-wide. They did an educational campaign to improve staff knowledge. That was with videos on staff Facebook pages, on the trust screensavers. They put posters around the hospital, and they updated their PPE policy. And they were able to reduce glove use by 4% and apron use by 22%. And so you can see again, there was also a significant savings, and they were suspecting that they also probably reduced common infections because people were keeping their gloves on inappropriately and spreading infections rather than reducing them. And the final one is quite a significant one from an HIV perspective. This was a team in North Hampshire, and the sort of guidance for HIV care within the UK is that we see patients every 6 months. But when you have patients who've maybe been living with HIV for 20 years, are very stable on their treatment, you're not really adding very much every 6 months other than giving them a new prescription. And so they looked at this, and they looked into doing annual reviews, and it was hugely successful. They saved a lot of environmental savings, financially also, but the most thing actually was from patient perspective. It was more convenient. They were able to identify that people were missing their work because of their appointments, because they didn't want to disclose that they were HIV positive, and a lot of people were in 0-hour contracts. And staff saved hours and hours of time that could be allocated to higher value work, and it also improved job satisfaction. So those are just 4 examples from a variety of different specialties, some more complicated, but some really straightforward, that show that when you implement SUS-QI, which is not too different to your normal QI processes, that you can end up with really improved clinical, environmental, financial, and social savings. So I'm just going to signpost you guys to a few resources to maybe look at this in a bit more detail. So this is one of our websites, susqi.org, and there's a QR code there. There is a step-by-step guide to doing your own SUS-QI project, and it basically talks through what I went through, but also gives you, blank templates that you can use for your own project. And also there's tables there for carbon emissions. So you don't have to necessarily go and try and find all the emissions. The most common emissions are already listed there in one of our documents. So I'd really encourage you guys to have a look at that website if this is something that you think you'd want to do. And QI projects are a part of our sort of ARCP within Foundation, so it's not too different from what you would normally do, and hopefully it will make a bigger impact. If sustainable healthcare is something that you're interested in, then I'd really encourage you to scan the QR code at the top for our networks. So we have networks of lots of health professionals around the world who sort of share things that they're partaking in, or whenever they've got questions or queries, put a post in there. We also update events and conferences and things like that. So there's like a general sustainable healthcare one, there's carbon footprinting, but we also have specialty specific ones. So if you're interested in primary care or in surgery or in anaesthetics or critical care, there are specific sustainable networks for those specialties as well. And we also some short courses. We offer short courses, sorry. So the intro to sustainable healthcare is quite similar to the beginning of of this talk, and then the SUSQI course will just expand on what I've been through. You can try and claim these back on study budgets if you have those available as well. That's how I did some of the short courses when I was earlier on in this pathway. And if you think that you want to spend a bit more time similar to how I have, then look out for fellowships. Join your green champion groups, or make friends with your sustainability managers or leads. Every hospital should have a green plan now, so you can look at that and maybe identify interventions that your hospital is also trying to back. So we have explored the relationship between the climate crisis and healthcare. I've talked you through the principles of sustainable clinical practice and the steps of the SUSQI framework, and I've showed you a few examples of SUSQI in the NHS. So I'm going to stop sharing my screen, and hopefully we can have a bit of discussion if there are any questions.
Thank you for that really informative talk, Ioma. Most of us now understand the importance of building sustainability into all areas of human activity, and obviously here specifically we're talking about healthcare, but many of us aren't sure where to start with taking action. I'm going to start us off with the questions. Ioma, can you summarize 2 or 3 of your top tips for foundation doctors to start to embed a sustainability approach into their practice?
I think the first thing would be, most hospitals will have green champion groups. So if you're feeling out of your depth, then maybe make links with that, because there are probably projects that are already ongoing that you could ask to be a part of, and then to see what the process is like. I think the SUSQI framework is quite a straightforward tool that you can adopt to make a change yourself, and it can be simple, like trying to reduce cannulation within an emergency department. It doesn't necessarily have to be changing a full pathway of care. So I think that's one of the benefits of SUSQI as a tool. So don't be afraid to try and use it. And then also, I think joining something like the network so you can see what's going on makes it all feel a bit more within your grasp and within your reach, because it might feel like sustainability is this thing that's going on around you and that you can't really get into. But if you put yourself in those spaces, things will come to you and opportunities will arise, and your understanding will improve, and you'll start to get the tools that you need to make changes. So I think those would be the 3 things that I would say.
That's great. Thank you, Ioma. So we haven't had any other questions from our attendees. So I'll move on to the next part of the webinar, which is, I'm pleased to confirm that we have just published a new section on the UKFPO website about sustainability and healthcare. The team will put the link into the Q&A, and we will also link to this from our webinars page, where you'll find the recording of this webinar. Please do visit this webpage for a summary of the information that Ioma has just provided, and for more general information and signposting to resources available to our foundation community about sustainability within QI and healthcare more generally. So the link has just been posted, so thank you very much. And like I said, we'll advertise that more widely as well. We will close the webinar here. So thank you again for sharing all of this information with us, Ioma, and for all of your work on preparing that website with us as well, that part of our website with us. And thank you very much to the UKFPO support team as well. Thank you for everyone who attended, and to everyone who is watching this webinar recording as well.